Welcome back to the deep dive. Today we're undertaking a really crucial knowledge extraction mission. We're focusing on one of the most specialized and frankly high stakes areas in surgery, pediatric urology.
Yeah, definitely high stakes. We're diving deep into the core concepts, the conditions, the pretty strict management protocols that define this field, all drawing from Daly and Love's Chapter 20.
Exactly. And this isn't just, a quick summary. We're aiming for a comprehensive, structured review. The idea is to make every essential detail instantly recallable for you, the listener.
That's spot on, because the challenges here are unique, aren't they? You're dealing with developmental anomalies, you need to maximize future function, minimize scarring in kids who are still growing. It demands absolute precision.
Right. So our mission today is to synthesize these foundational concepts. Everything from, say, basic foreskin physiology right up to complex reconstructions.
And making sure you understand not just what the conditions are, but why specific diagnostic pathways, specific surgical approaches are basically mandatory.
Precision is absolutely the watchword. So let's define our scope straight away. What are the major conditions we're tackling?
Okay, so we're covering the big ones. Hypospadias and its rarer counterpart, epispadias. We'll look at the really severe anatomy of bladder exstrophy.
Then there's the mechanics of vesicoureteric reflux, VUR.
Yep, VUR. Renal duplications too. Urolithiasis stones in children, which is maybe more common than people think.
And perhaps most critically, the whole spectrum of urinary tract obstruction.
Definitely. And, if you look across all these conditions, there are really two central themes that govern how we manage things in pediatric urology.
Okay, what are they?
First, it's the timing, choosing the right time to intervene. And that decision is completely reliant on getting accurate diagnostic imaging and a proper functional assessment first. You simply can't operate until you understand the dynamics.
Makes sense. And the second theme?
It's the surgical principle itself. Ultra-gentle tissue handling, scarring, contracture. These are catastrophic in growing, developing organs. So minimizing trauma isn't just nice to have, it's paramount for good long-term outcomes, both cosmetic and functional.
Right. Speaking of structure, the source material gives us a fantastic way to think about obstructive problems. It mentions these three main anatomical choke points where obstruction tends to happen.
Indeed. We need to kind of memorize these as the structural cornerstones. Level 1 is the ureteropelvic junction, the UPJ.
Okay, where the kidney pelvis meets the ureter.
Exactly. Level 2 is the ureterovesical junction, the UVJ, where the ureter actually enters the bladder wall.
Then level 3?
That's obstruction within the urethra itself. The most famous cause there, of course, is congenital posterior urethral valves, or PUVs. Understanding which level is blocked is really the first step when you're looking at something like fetal hydronephrosis.
Got it. Now, before we jump into specific clinical cases, maybe we should quickly ground ourselves in some of the embryology the chapter flags as critical, because a lot of this pathology stems from development going wrong.
Good idea.
Yeah.
Yeah, we need to recall the basics of testicular descent, the stages involved. We definitely need to understand the role of the urethral plate. Its failure to tubularize is what leads directly to hypospadias.
And also the complexities of morphological differentiation, which underpins differences of sex development, or DSD.
Absolutely. And diagnosing all these developmental issues hinges on specialized imaging. We'll be talking a lot about the workhorse high-resolution ultrasound.
And the crucial role of the voiding cysterotheography, the VCUG. We'll probably argue that's mandatory in certain scenarios, right?
Oh, definitely. And then there's the highly functional information we get from radioisotope scans, using technetium-99 99 millib TC.
Linked to either DMSA for static imaging.
Right, for fixed pictures of the kidney structure itself,
Uh-huh.
or linked to FG3 for dynamic flow assessment, seeing how things are actually draining.
Okay, brilliant overview. Let's start unpacking this, maybe beginning with the most common reason kids get referred to pediatric urology. Issues around the foreskin, circumcision decisions, and those developmental anomalies of the penis itself.
Right, pediatric urologists do spend a significant chunk of time dealing with foreskin issues. And often, the most effective tool isn't surgery, it's actually careful, targeted education and reassurance for the parents.
Let's start with the prepuce itself, the foreskin. The source describes it as this highly innervated, double-layered fold.
That's right. Anatomically, you've got an inner mucous membrane layer and an outer skin layer, and they meet at that very sensitive mucocutaneous zone.
And the book uses a great analogy, comparing its structure to things like eyelids or the labia minora, even the lips.
Yeah, those mucocutaneous junctions. But the key functional concept here is natural separation. A lot of people misunderstand this.
How so?
Well, foreskin is physiologically completely normally, adherent to the glands at birth. It's meant to be stuck down initially. Separation is a gradual thing,
Driven by what?
by accumulated gunk, essentially. Desquamated epithelial debris builds up, plus slight natural movements, and over time this plane develops. In most boys, it separates enough for the foreskin to be fully retractile by age 5.
And nearly all the rest before puberty hits.
Exactly. Which leads us straight to probably the single most important piece of advice in this whole section, something every clinician and parent needs to internalize.
Which is?
Forceful retraction is strictly not recommended, ever.
Needs bolding, underlining, everything. Why is it so bad?
Because when you try to forcibly retract a naturally adherent foreskin, you tear that delicate tissue bridge between the glands and the prepuce. It causes microtrauma.
Reading
Pain, bleeding, and critically scarring. And that scar tissue then turns what was a natural physiological adherence into a pathological, tight, fibrotic ring.
That's true phimosis.
And that then needs surgery, so the intervention actually causes the problem it was trying to fix.
Precisely. The initial adhesions were normal, non-pathological. The resulting scar is the pathology. Understanding that really helps when dealing with common parental anxieties. The source lists 3 things that often cause worry but are usually benign. First up, ballooning when the child urinates.
Ah, yes, the classic. Parents see the foreskin puff up with urine and panic. But it's usually just that developing plane starting to separate. Urine collects temporarily before passing through a slightly narrowed opening.
And the chapter explicitly says this is not an indication for circumcision.
Absolutely not. It often just resolves as the separation naturally progresses.
Okay, second common concern, urine spraying or a splayed stream.
Again, usually just a simple mechanical issue, maybe a bit of blockage or deflection. The fix is usually just teaching the parent or the child to gently draw back the prepuce a little before they start peeing, just to make sure the meatus, the opening, is clear.
Simple hygiene and technique, mostly.
Exactly. And the third one, which can look a bit alarming, is the smegma pearl.
Right, sounds mysterious. What is it?
It often causes the most anxiety because it looks like a hard white lump or nodule under the foreskin. But it's simply trapped smegma, that collection of skin debris and glandular secretions gathering in that slowly developing plane.
So harmless.
Completely harmless, non-infectious, and it will almost always discharge spontaneously once the plane fully opens up. No intervention needed, just reassurance. #TagBB. Indications and complications of circumcision.
Okay, let's move on to circumcision itself, the actual removal of the prepuce. The book notes it's the oldest and maybe the most common surgical procedure worldwide, affecting something like 40% of males.
That's the figure cited, yeah. And often driven by profound cultural or religious reasons, like the Jewish Brit Milah on the 8th day or the Muslim Khitan.
How does the technique differ depending on age?
It varies quite a bit. In early infancy, it's often done under local anesthetic using special clamps. The Plastibell or the Gumco clamp are common examples.
How do they work?
They provide a sort of controlled crush injury along the line of excision, which minimizes bleeding and often means no sutures are needed. The Plastibell leaves a plastic ring that falls off later.
And for older boys?
For older boys, it's a more formal excision procedure. Blade or scissors, usually under general anesthesia, requires meticulous hemostasis, stopping the bleeding, and then closing the skin edges, typically with fine absorbable sutures or sometimes surgical glue.
No, the complications list. It seems quite extensive, which maybe reflects how common the procedure is. We should detail this carefully. What are the immediate risks?
Immediate risks are bleeding, obviously, and infection. Early complications can include dehiscence, where the wound splits open.
And later risks.
Later on, you can get cicatrix formation that's excessive scarring. You can get persistent adhesions forming between the glands and any remaining foreskin edge. And then there are cosmetic concerns removing too much tissue, or perhaps not enough.
What about functional complications? Is meatal stenosis a big one?
That's a key long-term risk, yes. It's a narrowing of the urethral opening itself. It might not show up until later in childhood, presenting with a thin stream, difficulty urinating or spraying, and that often needs another procedure, usually a metotomy, to fix it.
And the really rare but devastating complications.
Well, thankfully exceedingly rare, but you can get actual injury to the urethra itself, or even, horrifyingly, partial or total amputation of the glands. It underscores why technique, care, and experience matter so much, even for what seems like a minor operation.
Okay, let's pivot to the necessary medical indications. When is circumcision genuinely required because of pathology? First up, true phimosis.
Right, true phimosis. This is the distinction we made earlier. This isn't the normal physiological adherence of a baby. This is a non-retractile foreskin, usually due to a tight, often fibrotic ring caused by scarring.
Scarring either naturally occurring or sometimes.
Or often iatrogenic, yeah. Caused by previous attempts at forceful retraction. If conservative measures like gentle stretching or steroid creams don't work, then circumcision becomes necessary to prevent urinary obstruction and chronic infection.
Okay, the second indication, and this sounds more complex, balanitis xerotica obliterans, or BXO.
BXO. Yes, it's a chronic, progressive inflammatory condition, possibly autoimmune in nature. It affects the foreskin and sometimes can extend down to involve the glands and even the distal urethra.
Is it common?
It's rare overall and almost never seen before the age of 5. But the presentation is quite distinctive. You get progressive phimosis, but the skin itself changes. It becomes white, kind of atrophic and hardened. That appearance is a real clinical red flag for BXO.
How do you manage it, and what's the key follow-up point?
Management is primarily circumcision, excising the diseased tissue. Sometimes, very mild early cases might respond to potent topical corticosteroids, but surgery is usually needed. And critically, because BXO frequently affects the urethral meatus itself, long-term follow-up is absolutely mandatory to watch for and manage meatal stenosis, which is a common consequence.
Got it. What about recurrent balanopostitis? That's inflammation of the glands and foreskin.
Yeah, most boys will probably have an episode or two of simple balanitis or balanopostitis at some point, maybe due to poor hygiene, irritation, or minor infection. These usually clear up easily with topical cleaning and maybe an antibiotic cream.
So when is circumcision indicated?
Only when it's genuinely recurrent and significant. We're talking multiple episodes causing real problems impacting quality of life, not just one or two isolated incidents.
Okay. Then there's the indication related to recurrent urinary tract infections, UTIs. But this seems quite specific.
Very specific. Circumcision is not recommended for general UTI prevention in otherwise healthy boys. However, in boys who have known significant underlying urinary tract anomalies, things like posterior urethral valves, severe reflux, conditions that already compromise the system, recurrent infection poses a much higher risk.
Risk of what specifically?
Risk of pyelonephritis, kidney infection, leading to renal scarring and potentially long-term kidney damage, even renal insufficiency down the line. So in these very specific high-risk cases, circumcision might be considered as part of a broader package of care aimed at reducing that serious infectious risk.
Right. It's about mitigating a known heightened danger. And finally, the acute emergency, paraphimosis.
Paraphimosis. This is a proper urological emergency. It's when a retracted foreskin gets trapped behind the head of the penis, behind the coronal sulcus.
And it acts like a tourniquet.
Exactly. It acts as a constricting ring, cutting off venous return from the glands. This causes rapid, painful swelling of the glands, and if it's not relieved quickly, it can lead to arterial compromise, ischemia, and even tissue necrosis.
So immediate action needed.
Absolutely. If simple manual reduction, gently squeezing the glands while easing the foreskin forward doesn't work promptly, then an emergency dorsal slit procedure, or even an immediate circumcision, is mandatory to relieve the constriction. #, see hypospadias and epispadias.
Okay, let's transition now into the developmental anomalies themselves, starting with hypospadias. That's the ventral defect, right? The openings on the underside. And it's pretty common.
Very common, relatively speaking. About 1 in 300 boys. It's one of the most frequent congenital malformations we see.
And the embryology is key again here. What goes wrong?
It boils down to that urethral plate we mentioned. Normally, under the influence of androgens, this plate forms a groove on the ventral side of the developing penis. The edges of that groove are then meant to fold over and fuse completely in the midline, a process called tubularization forming the penile urethra.
And in hypospadias?
That fusion process fails or is incomplete. So the urethra essentially opens out onto the surface too early, somewhere along the underside of the penis.
The source contrasts this with development in girls, which is interesting.
Yeah, it's a useful comparison. The homologous structure in girls, the vestibular groove, is actually programmed not to fuse. That's why it remains open, forming the labia minora. It highlights that hypospadias is really a failure of a specific required step in male development.
Anatomically, what are the defining features we see?
Well, the primary feature is the meatus, the opening being located ventrally. It can be anywhere from just slightly proximal on the glands, right down onto the shaft, the scrotum, or even the perineum in severe cases.
And there are usually associated features?
Almost always two others. First, there is often a ventral curvature of the penis itself, which we call a chordee. Second, there's a characteristic abnormality of the foreskin. It's deficient ventrally, meaning it doesn't wrap all the way around, leaving the skin kind of bunched up on the dorsal side. That gives the classic hooded prepuce appearance.
Okay, so when a baby is born with hypospadias, what are the absolute must-document points during the clinical assessment?
You need to be meticulous. Record the phallus length. Is it adequate? Note the precise meal location, glandular, coronal, penile, scrotal. Assess the gland's volume and the quality of the urethral plate itself. Is it deep, wide enough for repair? Document the degree of any chordee. Describe the foreskin appearance. And critically, you must check for the presence and location of both tests.
Why the testes check specifically?
Because hypospadias can be associated with undescended testes, and in some cases, particularly severe hypospadias with non-palpable tests, it might be the first clue towards an underlying difference of sex development, or DSD.
Right. And this brings us back to a vital point we touched on earlier regarding circumcision.
Yes. If a clinician identifies hypospadias in a newborn, routine neonatal circumcision is absolutely contraindicated.
Yeah.
Full stop.
Because?
Because that dorsal hooded foreskin, which might look a bit abnormal, is actually precious surgical real estate. It's often the primary source of graft material needed for the complex reconstructive surgery that will inevitably follow. Circumcising removes the best tool the surgeon has.
Okay. What are the aims of the hypospadias repair surgery itself?
The goals are essentially twofold. First, achieve a straight penis by correcting any chordee. Second, reconstruct the urethra so that the meatus is located at the tip of the glands in the normal position. This is crucial for allowing normal, forward-directed voiding for micturition and later in life for normal ejaculation.
Does the severity impact the surgical approach?
Massively. Distal defects like glandular or coronal hypospadias, where the opening is near the tip, are often managed successfully in a single-stage operation. But more proximal defects, those near the scrotum or in the perineum, or cases with very severe chordee, usually require complex, multi-stage procedures, sometimes spread over several months or even years.
Can you give an example of a common modern technique, say for distal repair?
Sure. A very common technique nowadays for many distal repairs is the tubularized incised plate urethroplasty, often called the tip procedure or the Snodgrass repair.
How does that work?
You make a deep incision down the middle of the existing urethral plate, which allows the edges to be mobilized and widened. Then you tubularize this incised plate, essentially rolling it into a tube around a small catheter or stent, forming the new urethra.
And for the more complex staged repairs?
For those, the first stage often involves correcting the chordee, straightening the penis first. Then that precious dorsal foreskin tissue might be deepithelialized and transferred ventrally as an onlay or inlay graft to create a healthy, wide urethral bed. Months later, in a second stage, this grafted tissue is then tubularized to form the final urethra.
These sound like demanding repairs. What are the common pitfalls or complications?
They are demanding, and despite meticulous technique, complications aren't uncommon. The most frequent is probably a urethrocutaneous fistula, a tiny leak, a hole forming between the newly constructed urethra and the skin surface.
What else?
Other potential issues include meatal stenosis, narrowing at the new opening, glands dehiscence, where the glands tissue doesn't heal properly around the new meatus, or recurrence of the chordee or persistence of the hypospadias itself, meaning the repair hasn't fully achieved its goals and further surgery might be needed.
Okay, quite a lot to manage there. Now, let's pivot sharply to the other end of the spectrum, anatomically speaking. Epispadias. This is the dorsal defect, and it's much rarer.
Significantly rare, yes. Here, the urethral opening isn't on the underside. It's located dorsally on the top surface of the penis. It can range from an opening near the penipubic junction, basically over the pubic bone, right up towards the glands.
And this is where the complexity really ramps up, because isolated epispadias is rare. It's usually part of a wider spectrum.
Exactly. Epispadias is almost always a component of the bladder exstrophy epispadias complex. This whole complex represents a major failure of ventral abdominal wall fusion during embryonic development.
So what does classic bladder exstrophy look like?
In classic bladder exstrophy, the bladder itself and the bladder neck are completely open and lie exposed on the surface of the lower abdominal wall. It's often associated with the pubic bones being widely separated, what we call diastasis.
And the most severe form of this complex, what's that called?
That's often termed cloacal exstrophy, sometimes ileocecal exstrophy. This is a devastating multisystem anomaly. The clinical picture is complex. You might see a small omphality, bowel herniating near the umbilicus. The cecum and terminal ileum might be everted onto the surface. The bladder is split into two halves, hemibladders, and the external genitalia are duplicated or severely malformed. The anus might also be imperforate or anteriorly displaced. It really signifies a catastrophic failure of midline closure.
Wow. The source offers quite a clear analogy to help visualize the difference between hypospadias and this extra-Chiffy complex.
It does. It suggests thinking of hypospadias as an incomplete cut or opening on the ventral or underside of the developing urethra. In contrast, the extrophy complex, including epispadias, is conceptually like a massive failure of closure, a split occurring on the dorsal aspect, extending proximally right through the pubic symphysis and into the bladder itself. It's a failure of fusion from the front of the body.
So for patients who have just isolated epispadias without the full bladder exposure, what's the primary long-term challenge?
It's almost always urinary incontinence, because the bladder neck is usually poorly formed, wide open, and the urethra is short. The sphincter mechanism is incompetent.
When is the penile reconstruction typically done?
The penile part of the reconstruction usually happens around age 2. However, the management is lifelong. The primary focus shifts to achieving continence, which often requires further complex surgery on the bladder neck or augmentation later on.
And there's a crucial monitoring aspect, too.
Absolutely. You have to vigilantly monitor the upper urinary tracts, the kidneys. Any obstruction created during the complex reconstruction of the bladder, neck, or urethra can lead to high back pressure, hydronephrosis, and progressive cumulative kidney damage over time. So long-term surveillance is key. #check2what. Urinary tract obstruction, reflux, and duplications.
Okay, that detailed look at penile anomalies leads us perfectly into the equally complex world of internal urinary dynamics. Let's start unpacking the obstructive mechanisms that can threaten the kidneys long-term. #tag, antenatal detection, and renal imaging.
Right. And often the very first warning sign for many of these conditions comes before the baby's even born. It's fetal hydronephrosis dilatation or swelling of the renal pelvis picked up on a routine antenatal ultrasound scan.
Is it common?
It's surprisingly common, actually, seen in about 1% of scans. Thankfully, the vast majority of cases are mild, transient, and resolve spontaneously without any consequence. But severe persistent dilatation definitely mandates careful postnatal investigation to rule out significant obstruction or vesicoureteric reflux, VUR.
Is there a specific antenatal clue that strongly suggests the most serious obstructive cause? Posterior urethral valves, PUV.
Yes, there's a classic triad, or at least a very strong association. It relates to the amniotic fluid volume.
How so?
Well, remember that amniotic fluid, especially later in pregnancy, is principally made up of fetal urine output. So if you see bilateral hydronephrosis, both kidneys dilated combined with severe oligohydramnios, meaning a significantly decreased amount of amniotic fluid.
That implies the fetus can't urinate properly into the amniotic sac.
Exactly. It strongly suggests a complete or near-complete obstruction at level 3 down in the urethra, most likely PUV. The blockage prevents the fetus from contributing urine to the amniotic fluid pool.
Can anything be done antenatally in those severe cases?
It's controversial and reserved for very severe, highly selected cases, but sometimes an antenatal intervention called a vesicoamniotic shunt might be attempted. This involves placing a small tube, shunt, from the fetal bladder out into the amniotic cavity, bypassing the obstruction.
What's the goal?
The hope is to relieve the pressure on the developing kidneys in utero, potentially preserving some renal function and allowing the lungs to develop better by restoring amniotic fluid volume. But it carries significant risks and is not routine.
Okay. So postnatally, we rely heavily on specialized imaging to figure out what's going on. Nuclear medicine scans seem key here. Let's dive into the 99 millitc radioisotope imaging.
Right. Technetium-99 meter is the workhorse isotope in pediatric nuclear medicine. It's ideal because it's a metastable isotope and it's only gamma rays, which are easily detected by the camera, and it has a convenient physical half-life of about 6 hours.
Meaning the radiation exposure to the child is relatively low and short-lived.
Exactly. And we use it by linking it to different tracer molecules, depending on whether we want to look at kidney structure or kidney function and flow.
Okay, let's start with static imaging using DMSA. What's that?
DMSA stands for dimercaptosuccinic acid. This molecule binds very tightly to the cells of the proximal renal tubules, the working tissue of the kidney cortex. We inject it, wait 2 or 3 hours for it to bind, and then take pictures.
And because it sticks to the tubules.
It gives us a beautiful, clear, fixed picture of the functional renal parenchyma, the kidney structure. We use DMSA scans to assess for things like renal agenesis, a missing kidney, to map out the anatomy in duplex systems, kidneys with two collecting systems, and perhaps most importantly, to identify areas of permanent scarring or functional loss.
How does scarring show up?
Scars appear as cold spots, areas where the DMSA hasn't been taken up because the tubular cells are damaged or absent. It's the gold standard test for diagnosing renal scarring associated with reflux nephropathy, which is kidney damage caused by VUR and infection.
Okay, that's static structure. What about dynamic imaging, using ABA3 or DTPA?
Right, these tracers are used to assess the dynamics, how the kidneys are handling urine flow, and how good their blood supply is. Dynamic imaging involves injecting the tracer and then capturing a rapid series of images over about 20-30 minutes, watching the tracer arrive at the kidneys, get taken up, and then excreted down into the bladder.
What can it tell us?
Well, if a kidney has very poor blood supply, it won't take up much tracer, and the image will look faint or absent. If there's a partial obstruction, say at the UPJ, the tracer will arrive okay, but its transit time out of the kidney would be significantly delayed. We can actually generate time activity curves, plotting the amount of tracer in the kidney over time, and compare the washout rate from the affected kidney to the normal side or to expected norms.
Now, there's a distinction made between MG3 and DTPA. Why might one be preferred over the other, especially in babies or suspected obstruction?
Yes, this is a subtle but really important point. DTPA, that's diethylene pentacetate, is handled by the kidney purely through glomerular filtration. It's filtered out of the blood by the glomeruli, just like creatinine. So the clearance of DTPA gives you a direct measure of the glomerular filtration rate, the GFR.
Okay, and MG3?
MG3 mercaptoacetotriglycine is different. It's extracted from the blood incredibly efficiently by the proximal tubules through active secretion. Its clearance correlates very closely with overall renal blood flow or effective renal plasma flow.
So why is MG3 often preferred in pediatrics?
Because it's extracted so much more effectively, especially by immature kidneys and neonates, or by kidneys whose function might be impaired by obstruction. It gives a much clearer picture of kidney perfusion and the kidney's ability to actually clear the tracer from the blood, even if the GFR is low. MG3 essentially tells us about blood flow and tubular function, which is often more relevant than just GFR when you're assessing obstruction and deciding if surgery is needed to improve drainage. #TAG the 3 levels of obstruction.
That detailed look at imaging sets us up perfectly to discuss those 3 main levels of obstruction again. Let's start with level 1, uretero-pelvic junction, UPJ obstruction, also called PJ obstruction sometimes, right? Pelviureteric junction.
Exactly. UPJ or PUJ, same thing. This is the most common cause of significant antenatal hydronephrosis that requires follow-up. It affects about 1 in 1,000 live births, maybe slightly more common in boys, and on the left side.
And it's basically a blockage where the kidney pelvis drains into the start of the ureter.
Precisely. It's a functional blockage preventing the free flow of urine out of the kidney.
What's the underlying cause usually? Intrinsic or extrinsic?
Most cases are intrinsic. It's thought to be a developmental abnormality right in the junction segment itself. Maybe the circular muscle fibers are disrupted or replaced by collagen, creating an adynamic, narrow area that just can't propel urine effectively through peristalsis.
And extrinsic causes.
Less common, but sometimes you can have an aberrant lower pole renal artery or vein crossing over the UPJ and physically compressing it from the outside.
Okay. We know it's often picked up antenatally, but if it presents later in older children, the presentation can be quite dramatic, can't it?
Oh, absolutely. The classic presentation in an older child is severe episodic intermittent pain, usually in the flank or upper abdomen, often accompanied by nausea and vomiting.
What triggers it?
It's often triggered by a large fluid intake, like drinking a lot quickly. This increases urine production. The pressure builds up rapidly behind the partial obstruction in the renal pelvis, causing distension and intense pain. This specific clinical picture has a name.
Dietl's crisis.
That's the one. Named after Joseph Dietel, who first described it. It's a useful term to remember severe, intermittent flank pain, maybe vomiting, often after drinking fluids. Think UPJ obstruction.
How do we confirm it and decide on surgery?
The MG3 scan is the key diagnostic tool here. It confirms the delayed drainage, the holdup at the UPJ. And crucially, it gives us the differential renal function. What percentage of total kidney function is coming from that affected kidney?
And what guides the decision to operate?
If the child is symptomatic, having Dietel's crises, or if the scan shows significant obstruction, poor washout after giving a diuretic like furosemide during the scan, or if the differential function of that kidney is falling, say, below about 40% or definitely below 35%, then surgery is generally indicated to prevent further damage.
And the standard surgical procedure is?
Pyeloplasty.
Can you describe what that involves?
The classic open pyeloplasty, or more commonly now the laparoscopic or robotic-assisted pyeloplasty, involves completely excising that narrow disease segment of the UPJ. Then you meticulously reconstruct the junction, anastomosing reconnecting the renal pelvis to the healthy ureter below it. The key is to create a wide, funnel-shaped, dependent opening to ensure completely unrestricted urine flow.
And follow-up is crucial.
Absolutely non-negotiable. Long-term follow-up with serial ultrasounds and sometimes repeat MBBS scans is needed to make sure the repair remains successful and the kidney drainage stays good over time.
Okay, let's move down to level 2. Ureterovesical junction, UVJ obstruction. This leads to primary megaretors, right?
That's right. UVJ obstruction is the second most common cause of antenatal hydronephrosis after UPJ obstruction. Here, the problem lies right at the other end of the ureter, where it tunnels through the bladder wall to enter the bladder cavity.
What's wrong with that segment?
It's usually a short segment that's intrinsically abnormal. It might be adynamic, meaning it lacks proper muscle function, or stenotic, meaning narrowed, or often a combination. This creates a functional obstruction just before the urine can get into the bladder.
We need to clarify the term megaretor. It just means a dilated ureter.
Exactly. Megaretor simply means an abnormally wide, dilated ureter. But we distinguish between primary and secondary causes.
So primary megaretor is?
Primary megaretor is when the dilation is caused by that intrinsic abnormality at the UBJ itself, the obstruction we just described.
And secondary megaretor?
Secondary megaretor is when the ureter is dilated because of a problem downstream, usually high pressure within the bladder itself. This could be due to a neurogenic bladder, or very commonly due to outlet obstruction from posterior urethral valves, PUV. The high bladder pressure effectively prevents the ureter from emptying properly, causing it to dilate backwards.
This raises a really important diagnostic challenge, doesn't it? The potential overlap between UVJ obstruction and VUR, vesicoureteric reflux.
This is probably the single most critical decision point in managing a dilated ureter. You see hydronephrosis on the ultrasound. The kidney and the ureter are dilated. But you absolutely must know why. Is it purely because of obstruction at the UVJ? Or is it because urine is refluxing back up from the bladder, VUR? Or could it even be a combination, a refluxing and obstructed megaretor?
So how do you differentiate?
The voiding cystourethropy, the VCUG, is absolutely mandatory in the workup of any megaretor. This test involves filling the bladder with contrast and taking x-rays while the child urinates. It's the only way to definitively rule reflux in or out.
Why is that distinction so crucial?
Because the management strategy is completely different. If it's primary obstructive megaretor causing problems, the treatment might eventually be surgical reimplantation of the ureter to fix the blockage. If it's high-grade reflux causing the dilation and potentially infections, the management might involve antibiotic prophylaxis, endoscopic injection therapy, or again, ureteric reimplantation, but for a different reason to fix the faulty valve mechanism. You have to know which it is.
And the MBBS scan still plays a role.
Yes. Once you've ruled out significant reflux with the VCUG, the MBBS scan helps determine the severity of the obstruction at the UVJ and the impact on kidney function, guiding whether intervention like reimplantation is actually needed.
Okay. Now for level 3. Posterior urethral valves, PUVs. The obstruction is in the urethra itself.
Yes. PUVs are these thin, sail-like membranes or folds of tissue located within the posterior urethra just below the bladder neck. They act like one-way valves, severely obstructing the outflow of urine from the bladder during voiding.
And this is a male-only condition?
Exclusively affects boys, yes. Affects about 1 in 4,000 live-born boys, so while not super common, it's the most common cause of severe bladder outlet obstruction in male infants.
We mentioned the antenatal red flags, bilateral hydronephrosis, dilated bladder maybe, and crucially, oligohydramnios. How is the diagnosis definitively confirmed after birth?
Again, the VCUG is the gold standard, absolutely essential. As the baby voids during the study, the x-rays will show the classic diagnostic features, which you'll see marked dilatation of the posterior urethra down to the point of the valves. Proximal to that, you'll often see a thickened, trabeculated, irregularly surfaced bladder wall reflecting the high pressure it's been working against. And frequently, you'll also see vesicoureteric reflux, VUR, occurring because the high bladder pressure has overwhelmed the UVJ valves.
You mentioned the keyhole sign on antenatal scans.
Yes, sometimes on antenatal ultrasound, you can see the dilated bladder and the dilated posterior urethra together, which gives this characteristic keyhole appearance, strongly suggesting PUV.
Now, the treatment is surgical ablation of the valves, right? But what's the really sobering point about the long-term prognosis for these boys?
The initial treatment is indeed prompt endoscopic valve ablation or resection, cutting those membranes to relieve the obstruction. That's crucial. However, the real tragedy of PUV often lies in the long-term consequences for the bladder and kidneys.
Why? What's the permanent damage?
Because the bladder has been contracting against such severe obstruction, often since fetal life, its muscle wall, the detruther, frequently undergoes irreversible changes. It becomes hypertrophied, thick-walled, poorly compliant, stiff, and generates abnormally high storage pressures. Even after the valves are successfully cut, this valve bladder dysfunction often persists.
And the consequence of that high-pressure bladder?
It leads to a persistently hostile environment for the upper tracts. High pressures can cause ongoing or worsening VUR or functional obstruction at the UVJs, leading to progressive hydronephrosis and kidney damage over years. And the stark reality, the statistic that really defines the seriousness of PUV, is that around 30% of boys born with PUV will eventually progress to end-stage renal failure, requiring dialysis or transplantation, often during adolescence or early adulthood.
Wow, even with successful initial surgery.
Even with successful valve ablation, it underscores why these boys need meticulous, lifelong urological follow-up, focusing not just on the urethra, but critically on bladder function and protecting those kidneys. #tag CUR, vesicoureteric reflux VUR.
That leads us nicely into discussing VUR itself, the backward flow of urine from the bladder up towards the kidneys.
Right. VUR is basically a failure of the normal one-way valve mechanism at the uretero-vesical junction, UVJ.
And like megarators, we distinguish between primary and secondary VUR.
Exactly. Primary VUR is the most common type, probably affects about 1% of newborns. It's due to a congenital anatomical issue. The tunnel that the ureter takes through the bladder wall is too short, or the angle of entry is wrong. This means the natural flap valve mechanism, which normally closes the ureter opening when the bladder contracts, is incompetent. So when the bladder squeezes to empty, urine flows backwards up the ureter.
And secondary VUR.
Secondary VUR is when the UVJ valve mechanism itself might be anatomically normal, but it fails because it's being overwhelmed by extremely high pressure within the bladder. We see this typically in conditions like PUV, as we just discussed, or in severe neuropathic bladder dysfunction. The high intravesical pressure essentially forces the valve open from below.
And the main danger of VUR isn't the reflux itself, but the risk of infection.
Precisely. VUR is the primary pathway by which bacteria causing a simple bladder infection, cystitis, can easily travel up to the kidney, causing pyelonephritis. Repeated episodes of pyelonephritis are what lead to renal scarring and permanent kidney damage, known as reflux nephropathy.
How do we diagnose and grade VUR?
Again, the VCUG is the diagnostic standard that not only confirms the presence of reflux, but also allows us to grade its severity, typically using an international scale from grade 1, reflux only into the ureter, up to grade V, massive reflux with gross dilation and tortuosity of the ureter and dilation of the renal pelvis and calyces.
How does the grade influence management?
It's a key factor. Mild low-grade VUR, say grades worse than 2, has a very high chance of resolving spontaneously as the child grows. As the bladder grows, the intravesical ureter effectively lengthens, improving the valve mechanism naturally.
So those kids are often just watched.
Yes, if they are older and toilet-trained, often just surveillance is needed. If they are younger, still in diapers, and thus at higher risk of UTIs, they might be managed with continuous low-dose prophylactic antibiotics to prevent infections while waiting for spontaneous resolution.
But moderate to severe VUR, grades 3rd, 4, V, is more concerning.
Much more concerning. The risk of breakthrough UTIs, pyelonephritis, and subsequent renal scarring is significantly higher with high-grade reflux. Spontaneous resolution is also less likely. These children are more likely to require intervention.
What are the intervention options?
There are broadly 2 main approaches. One is endoscopic treatment. The most common procedure is often called Esteen's seborrheic Teflon injection, although nowadays other bulking agents like deflux are more commonly used. This involves injecting a small amount of this substance under the refluxing ureteral orifice inside the bladder, aiming to bulk up the tissue and improve the valve's closure.
And the other option?
The other is open surgical ureteric reimplantation. This is a more definitive procedure where the surgeon disconnects the ureter from the bladder, creates a new, longer submucosal tunnel for it within the bladder wall, and then reattaches the ureter. This surgically reconstructs a highly effective anti-reflux valve mechanism. The choice between endoscopy and open surgery depends on grade, laterality, patient age, surgeon preference, and previous treatments. #tag duplex systems.
Okay, let's touch on duplex systems. This is where you have two collecting systems, two ureters draining a single kidney. That's relatively common, right? Maybe 1 in 100 people.
Yeah, around that figure, although clinically significant duplex systems are less common. It's an anatomical variation where the kidney develops with two separate pelvically sealed systems, each drained by its own ureter. These ureters might join together partway down, partial duplication, or run all the way separately to the bladder, complete duplication.
And it's the complete duplication that leads to one of the really interesting, almost counterintuitive rules in urology, the Weigert-Meyer rule.
Ah, yes, Wigert and Meyer. This rule describes the relationship between the two ureters in a complete duplication and where they insert into the bladder. It states that the ureters draining the upper pole, or upper moiety, of the kidney follows a longer, more wandering course. It crosses over the lower pole ureter and ends up inserting into the bladder more inframedially, that is, lower down and closer to the midline, compared to the orifice of the ureter draining the lower pole moiety.
So the upper pole ureter inserts lower down. That seems backwards.
It does seem backwards, but that's the rule.
Yeah.
And it has really important clinical consequences because this abnormal insertion pattern predisposes each moiety to completely different problems.
How so?
Well, because the upper pole ureter inserts so low down and often tunnels for too long beneath the bladder mucosa, it's prone to becoming obstructed at its entry point into the bladder. This obstruction can sometimes lead to the formation of a ureter chill.
What's a ureter chill?
It's a cystic dilatation of the very end of the ureter, where it bulges into the bladder lumen like a little balloon because its opening is tiny or obstructed. These are often associated with the upper pole ureter in a duplex system.
Okay, so the upper pole ureter is prone to obstruction or uretersol. What about the lower pole ureter?
Conversely, because the lower pole ureter inserts higher up and more laterally on the bladder wall, its intravesical tunnel is often too short. And just like in primary VUR, a short tunnel means an incompetent valve mechanism. So the lower pole moiety in a duplex system is predisposed to reflux.
Wow, so you can have obstruction in the upper part and reflux in the lower part, all in the same duplicated kidney.
Exactly. It's a classic combination of pathologies arising directly from that Weigert-Meyer anatomical arrangement.
And the source also mentions another consequence of these ectopic ureters wetting.
Yes, that's particularly relevant if the ectopic ureter, usually the upper pole one, inserts outside the bladder neck sphincter mechanism altogether. In girls, this might mean it opens into the urethra distal to the sphincter, or even into the vagina or the vulval vestibule.
What's the clinical result?
The result is continuous urinary incontinence, constant dampness, because urine from that upper moiety is bypassing the bladder's continence mechanism entirely. It's a rare but important cause to consider in a girl presenting with constant unremitting wetting, rather than the episodic incontinence you see with bladder dysfunction. Hashtag tag 3, urolithiasis and specialized urological reconstruction.
Okay, let's shift gears now and talk about urolithiasis, stone disease, specifically in children. We tend to think of stones as an adult problem, but the source notes a rising prevalence globally.
Yes, the prevalence seems to be increasing, although it varies widely. Maybe 1% in some parts of Asia, but reportedly up to 15% in some regions of North America. And the crucial thing to remember is that a stone in a child is rarely idiopathic or without cause, unlike in many adults.
So we always need to look for an underlying reason. What are the main categories?
Broadly, 3 categories. First, metabolic factors. This is key. Things like hypercalciuria, too much calcium in the urine, hyperoxaluria, too much oxalate, or hypocitraturia, that's low levels of citrate in the urine. Citrate is a really important natural inhibitor of stone formation, so low levels are a significant risk factor.
Okay, metabolic, what's second?
Infection. Around 25%, maybe a quarter, of stones in children are infection-related. These are typically caused by specific bacteria that produce an enzyme called urease organisms, like Proteus mirabilis or Klebsiella pneumonia, are common culprits.
How does urease cause stones?
Urease breaks down urea, a waste product in urine, into ammonia. This makes the urine highly alkaline, which causes minerals like magnesium, ammonium, and phosphate to precipitate out and form characteristic struvite stones, sometimes called infection stones or triple phosphate stones. These can grow very rapidly and sometimes fill the entire collecting system, forming large Staghorn calculi.
And the third category of risk factors?
Anatomic factors that lead to urinary stasis, poor drainage. Anything that causes urine to sit around for too long allows crystals more time to aggregate and form stones. So conditions like UPJ obstruction, congenital anomalies like polycystic kidney disease, or again, the poor emptying associated with a neurogenic bladder all increase the risk.
How might a child with a stone present Is it always the classic adult picture of severe flank pain radiating to the groin?
Sometimes, yes. Older children might present with that classic renal colic, maybe growth hematuria, visible blood in urine, dysuria, pain on urination. But especially in younger children, the symptoms can be much more vague and nonspecific. Things like nausea, vomiting, general abdominal discomfort, irritability, or even just recurrent UTIs without obvious pain. This can sometimes lead to diagnostic delays.
When it comes to imaging, how do we balance the need for diagnosis with concerns about radiation exposure in kids?
That's a critical consideration. Unlike in adults, where a non-contrast CT scan is often the first-line investigation for suspected colic, we try to minimize radiation in children. Ultrasound is usually the initial imaging modality of choice.
Is ultrasound good enough?
It's excellent for detecting hydronephrosis caused by an obstructing stone, and it can directly visualize most stones within the kidney or bladder quite easily, and is completely radiation-free.
When might CT be used?
Non-contrast CT is undoubtedly the most sensitive test for detecting stones anywhere in the urinary tract, regardless of their composition, and it gives precise information about size and location. It might be used if the ultrasound is inconclusive, if complex anatomy is suspected, or for preoperative planning for larger stones. But the decision to use CT must always weigh the diagnostic benefit against the lifetime risk of ionizing radiation exposure in a child. Sometimes low-dose protocols can be used.
Okay. How is management approached? Does it start conservatively?
For small stones that aren't causing severe obstruction, significant pain, or infection, yes, the initial approach is often conservative or expectant management. This involves encouraging high fluid intake to try and flush the stone out, and providing adequate pain relief, analgesia.
What if there's infection involved with the stone?
A stone causing obstruction and infection is a urological emergency. This requires immediate hospital admission, intravenous hydration, broad-spectrum antibiotics to cover the likely organisms, and usually prompt drainage of the obstructed kidney, either by inserting a ureteric stent endoscopically or placing a percutaneous nephrostomy tube directly into the kidney through the back to relieve the pressure and prevent life-threatening urosepsis.
Are there medications that can help stones pass? Medical expulsive therapy?
Yes, although much of the evidence is extrapolated from adult studies, medications like alpha blockers, for example tantalocin, or calcium channel blockers, for example nifedipine, are often used.
How do they help?
The theory is that they relax the smooth muscle in the distal ureter, potentially reducing spasm and ureteric colic and facilitating the passage of the stone. They seem to target the painful dismodal contractions while preserving the forward peristalsis needed to push the stone along.
Okay, if conservative management fails or isn't appropriate, what are the main interventional options for removing stones in children? Let's start with the least invasive, ESWL.
Right, ESWL stands for extracorporeal shockwave lithotripsy. This uses focused, high-energy sound waves generated outside the body to break the stone into smaller fragments, which can then be passed naturally in the urine. It's generally effective for stones less than about 2 centimeters in size, located in the kidney or upper ureter.
Is it done awake?
In children, ESWL almost always requires general anesthesia to ensure they remain perfectly still during the treatment for accurate targeting of the shock waves.
What if ESWL isn't suitable or fails? What's the next step up? Maybe ureteroscopy.
Yes, ureteroscopy URS is often the next option. This involves passing a very fine, semi-rigid or flexible telescope up through the urethra and bladder into the ureter, right up to the stone.
And then what?
Once the stone is visualized directly, it can be fragmented using a laser fiber passed through the scope, and the pieces can then be actively removed using tiny baskets or graspers. URS is highly effective for stones in the ureter and also for smaller stones within the kidney, generally less than 2 centimeters. However, we tend to avoid it in very young children, say under 5, due to the extremely small caliber and fragility of their ureters.
Okay. And the most invasive option for the biggest or most complex stones, PCNL.
Exactly. PCNL stands for percutaneous nephrolithotomy. This is reserved for large stones, typically greater than 2 centimeters. Complex stones like staghorn calculi, stones that have failed treatment with ESWL or URS, or situations with multiple large stones.
How is it performed?
It involves creating direct access into the kidney's collecting system from the outside, through a small incision in the flank. A tract is dilated into the kidney, allowing larger instruments, a nephroscope, to be passed in to visualize the stone, break it up, using ultrasound, laser, or pneumatic devices, and suction out the fragments. It's the most invasive, but also the most effective method for clearing a large stone burden in a single session. #B neuropathic bladder and complex reconstruction.
Okay, let's shift now to the really complex end of pediatric urology, managing the neuropathic bladder, which often requires highly specialized reconstruction.
Yes, the neuropathic or neurogenic bladder is a major challenge. It results from underlying neurological conditions that disrupt the normal nerve supply controlling bladder function.
What are the common causes?
The most common cause by far is myeloma megacili, the most severe form of spina bifida. But it can also result from other spinal cord issues like myelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelomyelom canal.
And the lack of proper nerve input messes up bladder function how?
It leads to uncoordinated bladder activity. The bladder might be areflexic, unable to contract, or more commonly, hyperreflexic, contracting involuntarily at low volumes. Often, the sphincter muscle is also uncoordinated, detrusor sphincter dyssynergia. The net result is usually a bladder that stores urine at dangerously high pressures, doesn't empty well, and is prone to incontinence and reflux.
So what are the absolute fundamental lifelong goals when managing a child with a neuropathic bladder?
There are really two overriding goals, and they are inseparable. First, and most importantly, you must protect the upper tracts, the kidneys. This means keeping bladder storage pressures low and preventing or treating VUR to avoid hydronephrosis and renal damage. Kidney preservation is paramount.
Yeah, the second goal.
The second goal is to achieve social continence and maximize the child's independence and quality of life. This is incredibly important as they grow older. Managing a neuropathic bladder is almost always a lifelong pathway of care.
When conservative measures like medications and intermittent catheterization aren't enough, and major reconstructive surgery is being considered, what does the preoperative assessment need to cover? It sounds complex.
It's highly specialized. It requires detailed urodynamic studies to objectively measure bladder capacity, compliance, how stretchy the bladder is, storage pressures, and detect any involuntary contractions. We need to assess the function and competence of the bladder neck and sphincter mechanism. We need to determine if the child will be able to catheterize urethrally or if they'll need an alternative channel created. And often, we need to consider concurrent management of bowel incontinence too, as these issues frequently coexist.
Let's break down the main types of complex surgical interventions that might be needed, starting with procedures to improve continence by addressing the bladder outlet, the sphincter.
Right. If the bladder neck or sphincter is incompetent, leading to leakage, several options exist. These can range from minimally invasive endoscopic injections of bulking agents around the bladder neck to placing a sling using fascia or synthetic material to support and compress the urethra, to more complex open surgical reconstructions of the bladder neck itself. In the most severe cases where continence via the urethra isn't achievable and drainage will be managed entirely through a channel, a complete surgical closure of the bladder neck might be performed.
Okay. What if the main problem isn't the outlet, but the bladder itself? It's small, stiff, generating high pressures that threaten the kidneys.
That's when we consider bladder augmentation. The standard workhorse procedure here is ileocytoplasty.
How does that work?
It involves taking a segment of the patient's own ileum, small bowel, carefully isolating it on its blood supply, detubularizing it, opening it up into a flat patch, and then sewing this patch onto the opened bladder dome.
What does that achieve?
It dramatically increases the bladder's capacity and, crucially, improves its compliance. It turns a small, stiff, high-pressure bladder into a large, floppy, low-pressure reservoir. This protects the kidneys from damaging back pressure and often significantly improves continence between catheterizations.
Now, this leads us to what you called the aha moment for the learner, the procedure that really empowers patient independence, especially after augmentation. The Mitrofanoff procedure.
Ah, yes, the Mitrofanoff principle, usually performed as an appendicosectomy, named after Professor Paul Mitrofanoff, who pioneered it. This is truly transformative for many patients.
What does it involve?
It typically uses the patient's own appendix. The appendix is detached from the bowel but kept on its blood supply. One end is connected to the bladder, and the other end is brought out to the skin surface, usually discreetly hidden within the umbilicus or somewhere else on the lower abdomen, creating a small stoma.
And the magic is how it connects to the bladder.
Exactly. The appendix is tunneled through the bladder wall in such a way that it creates a natural, continent flap valve mechanism. This means urine doesn't leak out of the stoma, but the child can easily pass a catheter through the stoma, down the appendix conduit, and directly into the bladder to empty it regularly.
So it provides an alternative to urethral catheterization.
Precisely. For patients who find urethral catheterization difficult, painful, or socially unacceptable, especially wheelchair users or those with limited hand dexterity, Having a Mitrofanoff channel provides a much easier, more discreet way to manage their bladder emptying via intermittent self-catheterization. It dramatically improves independence, self-care, and quality of life, often performed alongside or after a bladder augmentation. Hashtag TAG5EDDY. Disorders of sex differentiation, DSD, and testicular pathology.
Okay, we're moving now into what is arguably the most sensitive, ethically complex, and clinically demanding area, differences of sex differentiation, or DSD.
Yes, this area requires immense sensitivity and expertise. DSD is the umbrella term for congenital conditions where there's an abnormality in the development of chromosomal sex, gonadal sex, the testes or ovaries, or anatomical sex, the internal or external reproductive structures.
The source makes an important clarification about what isn't DSD.
That's right. It specifically excludes conditions like isolated undescended tests, simple hypospadias, without other ambiguities, or labial adhesions. While these are congenital issues, they don't fall under the DSD classification, which implies a more fundamental discordance in sexual development pathways.
Given the complexity, genetic, endocrine, surgical, psychological, ethical, ethicary, the management structure seems absolutely non-negotiable.
Completely non-negotiable. The management of any child with suspected DSD must be conducted by a dedicated, experienced multidisciplinary team, MDT.
Who needs to be on that team?
It has to include pediatric urologists or surgeons, pediatric endocrinologists, clinical geneticists, often adolescent gynecologists for female aspects, and critically, specialist pediatric psychologists or psychiatrists and social workers. Getting consensus on investigations, gender assignment if ambiguous, the timing and type of any potential surgery, it's incredibly complex and often controversial, making that collaborative MDT approach absolutely essential from day one.
Let's look at the broad categories, starting with 46XX DSD. The classic example here is congenital adrenal hyperplasia, CAH.
Right. In CAH, the individual is genetically female, 46 chromosomes, XX. But due to an enzyme defect in the adrenal gland, they produce excess androgens, male hormones, during fetal development. This leads to virilization of the external genitalia.
So the assigned gender is usually female.
Yes. The gender of rearing is usually female, consistent with the chromosomal and gonadal sex, unless perhaps there's a very late diagnosis after significant virilization has occurred. But at birth, the external genitalia can look highly ambiguous.
How ambiguous?
It can range from mild clitoromegaly to severe virilization that looks very much like a 46XY boy with severe hypospadias and non-palpable tests due to fusion of the labioscrotal folds and a large phallus-like clitoris.
Is there a defining anatomical feature internally in 46XXCAH?
The key internal anatomical feature is the persistence of a urogenital sinus. This means the vagina doesn't open separately to the outside, but instead opens into the posterior wall of the urethra. The level of this connection can vary, but the source notes it's typically never higher than the verumontanum would be in a male urethra. Surgical reconstruction, usually timed carefully, often involves procedures like vaginoplasty and potentially clitoral reduction or recession.
Okay. Now the other main group, 46XY DSD. This includes conditions like androgen insensitivity syndrome, AIS, and enzyme deficiencies like 17-HSD or 5-reductase deficiency.
Right. In these conditions, the individual is genetically male, 46XY, and has testes. But there's a problem either with androgen production or, more commonly, with the body's ability to respond to androgens.
Let's take complete AIS, CASS first.
In CAA, the body cells are completely unresponsive to androgens. So despite having XY chromosomes and testes, which produce testosterone, the external development follows a female pathway. These individuals have a female phenotype, are raised as girls, and often present in infancy, maybe with bilateral inguinal hernias containing testes, often mistaken for prolapsed ovaries, or later in adolescence with primary amenorrhea, failure to menstruate as they lack a uterus.
And what about the enzyme deficiencies like 5-reductase deficiency?
In conditions like 5-reductase deficiency or 17-hydroxysteroidehydrogenase deficiency, the testes produce testosterone, but the conversion to the more potent dihydrotestosterone, DHT, or the final synthesis step, is impaired. This leads to undermasculinization of the external genitalia at birth. So a 46XY infant might be born with ambiguous genitalia, maybe resembling severe hypospadias.
But what happens at puberty?
This is the crucial point. Because the tests are present and often function, these individuals typically experience significant virilization, masculinization, like voice deepening, muscle growth, phallic enlargement at the time of puberty due to the pubertal surge in testosterone. This potential for dramatic change at puberty is where the controversy around early gender assignment and surgical decisions becomes particularly acute in these specific conditions.
And this leads directly to the core ethical controversy highlighted in the source, particularly concerning the fate of the testes in individuals being raised female.
Yes, it's a profound and highly debated issue. What should be done with the gonads, testes, in a 46XY individual assigned a female gender of rearing?
What are the arguments?
On one hand, there's an argument for early gonadectomy, removal of the testes, in childhood.
Hmm.
The rationale is to prevent the unwanted, potentially distressing virilization at puberty, and also to remove the theoretical long-term risk of gonadal malignancy, as testes located intra-abdominally or in an abnormal position have a slightly increased cancer risk.
And the argument against early removal.
The counter-argument, which has gained considerable traction, is that irreversible surgical decisions, particularly gonadectomy, should ideally be deferred until the individual is old enough to understand the implications and participate meaningfully in determining their own gender identity and making informed choices about their own body. Removing the gonads removes the potential for endogenous hormone production later.
If the decision is made to wait to preserve the gonads temporarily, how can the risk of unwanted virilization at puberty be managed?
The source notes a potential strategy here. If the gonads are preserved, the expected pubertal virilization can be temporarily blocked medically using a GnRH analog that's a gonadotropin-releasing hormone analog. This effectively puts puberty on hold, buying time until the individual is mature enough to make those deeply personal, informed decisions about their identity, potential future surgery, and hormone replacement.
It's incredibly complex territory. Finally, let's briefly mention sex chromosome mosaicism, like 45,000X46XY DSD.
Right. These individuals have a mix of cell lines, some cells with only one X chromosome, like Turner syndrome, and some with a normal male XY complement. The presentation is often highly variable, but frequently includes significant asymmetry of the external genitalia.
What might that look like?
You might see, for example, a hemiscrotum on one side containing a gonad that looks somewhat like a testes, paired with a structure resembling a labia majora on the other side, often containing a streak gonad, which is basically non-functional fibrous tissue where an ovary or testes failed to develop properly. This is almost always accompanied by severe hypospadias and varying degrees of genital ambiguity. Management here is also highly individualized and requires that full MDT approach, ###B, testicular tumors.
Okay, let's finish this section by turning to testicular tumors in childhood. The first point to stress is rarity.
Yes, thankfully, testicular tumors are rare in the pediatric population overall.
But the age of presentation seems absolutely critical for management approach.
It is. There's a really important distinction. Most testicular tumors that arise in the prepubertal years, particularly those occurring before the age of 3, are typically benign.
And the implication of that?
Because they are usually benign in this very young age group, testis-sparing surgery is often the preferred approach. This means just excising the tumor itself, enucleation, while preserving the rest of the healthy testicular tissue, avoiding orchidectomy if possible.
But the situation changes in older boys.
Yes, malignant testicular tumors, while still uncommon, become relatively more frequent in older boys and adolescents. And if malignancy is suspected or confirmed, the management needs to be immediate and follow standard oncological principles.
What's the critical surgical rule here?
The absolute rule for suspected testicular malignancy is that the orchidectomy removal of the testicle must be performed via an inguinal groin incision, clamping the spermatic cord high up first. A scrotal approach is contraindicated because it risks violating lymphatic drainage pathways and potentially seeding tumor cells into the scrotum, which can significantly worsen the prognosis and complicate further treatment.
And surgery might be followed by?
Depending on the specific tumor type, histology, and stage, orchidectomy might be followed by surveillance, retroperitoneal lymph node dissection, or selective chemotherapy or radiotherapy based on established protocols.
Can we briefly categorize the types of tumors seen?
Broadly, they fall into two main groups. First, you have germ cell tumors. In young children, this includes teratomas and epidermoid cysts, which are often benign. But it also includes the highly malignant yolk sac tumors, also called endodermal sinus tumors, and later in adolescence, seminomas become more common.
And the second group?
The second group is gonadal stromal tumors. These arise from the supportive tissues of the testes, the cells that produce hormones or support sperm development. Examples include Leydig cell tumors, Sertoli cell tumors, and juvenile granulosa cell tumors. These stromal tumors tend to be benign in the pediatric age group, although malignant potential exists, especially in older patients. Hashtag Kagetro.
Right. That was an incredibly dense, but hopefully very structured deep dive into the absolute essentials of pediatric urology based on Bailey and Love. To really synthesize the huge amount of detail we've covered, let's quickly consolidate some of those non-negotiable revision points.
Okay, I think we established the core structural thinking around those three levels of obstruction: UPJ, UVJ, and PUV. Understanding where the block is fundamental.
And the critical role of the VCG.
Absolutely. We highlighted why VCUG is mandatory for investigating VUR and diagnosing PUV, and we really stressed that long-term morbidity for PUV kids often stems from that persistent high-pressure, poorly compliant valve bladder, leading to that sobering 30% risk of eventual renal failure, even if the valves were perfectly ablated initially.
We also hit those crucial surgical rules, why you absolutely must preserve the foreskin and hypospadias for potential repair.
And why you have to be vigilant for meatal stenosis after treating BXO, as it's a common complication.
And we clarified the nuances of advanced imaging, particularly why MB3, assessing dynamic blood flow and tubular clearance, is often superior to DTPA, which measures GFR, for evaluating function in neonates and cases of suspected obstruction.
Exactly. And finally, we covered the hierarchy of stone management, from non-invasive ESWL up to the highly specialized PCNL for large burdens. And importantly, the rationale behind complex reconstruction for the neuropathic bladder, procedures like ileocystoplasty for augmentation, and the genius of the Mitrofanov channel for catheterization.
They're not just nice to have surgeries, are they?
Not at all. They are essential functional procedures, designed first and foremost to protect the kidneys from high pressure, and secondarily, to grant the child as much independence and quality of life as possible.
This deep dive really underscores that the work done by pediatric urologists is so often just the beginning of a very long journey for these patients and their families. The success or limitations of that initial intervention profoundly shapes their entire future, which I think leads us perfectly into our final provocative thought for you, the listener, to mull over.
Yeah, think about this. We discussed how conditions like neuropathic bladder, bladder exstrophy, severe PUV often require extensive complex reconstructions and inevitably need lifelong specialist follow-up. Now, given that dedicated pediatric urological care eventually has a cease, usually when the patient reaches late adolescence or early adulthood, they have to transition into the adult surgical and medical system. So the question is, how should the necessity of ensuring a smooth, well-documented, and effective transfer of care into adult services influence the initial choice of surgical procedures and the long-term follow-up strategies that the pediatric team implements today? Does planning for that handover decades down the line change what we do now?
That transition moving from pediatric-centered care to navigating the adult chronic care system is perhaps the final and sometimes overlooked critical step in these complex, lifelong surgical pathways. Something definitely worth considering. Thank you for taking this very specialized deep dive with us today. We'll catch you next time.